welcome. Nice to see you all. We got a good group here. Really excited for this session. So I'll dive in, so I won't take any more time. Welcome to this CIN webinar on improving behavioral health equity for peri and postpartum Latinx patients with depression. So during this hour, we're really hoping for a conversation. You'll get to learn how Cherokee Health Systems, which is an integrated federally qualified health system in Tennessee, redesigned workflows and clinical practices to improve the identification and treatment of depression for their Latinx patients. So my name is Marie Hubbard. I'm a program manager for the California Improvement Network, also known as CIN. CIN is a learning and action network that works to advance the Quadruple Aim by spreading better ideas for care delivery. CIN is truly fueled by the energy and innovations of our partners and members, so all of you. And really the work that we do is driven by the work that you all are doing at your organizations and in your communities. CIN is funded by the California Healthcare Foundation and managed by Health Force Center at UCSF. You can learn more about our organizations by going to our websites located here. A few quick tips before we dive in. Everyone is on mute. We will be spending part of the hour hearing from our speaker. And then the second half of the hour will be really in conversation. So hopefully you all will have a chance to ask your questions and kind of discuss about what you learned during the first part of this hour. We will be recording this webinar and posting it on our website for those who are interested in referencing the material later on. If you have any questions or tech issues, please direct message my colleague, Christina Travalos, and she will help you as needed. So with that, I'm excited to introduce our speaker, Dr. Perinda Khatri. She's the Chief Clinical Officer at Cherokee Health Systems, and I will pass it off to you, Perinda, to get us started.
Thank you. Thanks so much, Marie. And hello, everyone. I'm really excited to be able to talk with you today. And as Marie noted, I hope this is a conversation. You know, what I'm hoping to do is just share our story. That, we don't know perfectly what works with everyone, but I'm hoping that just by sharing our story and our journey and how we've had some lessons learned that have informed our approach, that may be something that resonates with you all, and certainly would love to hear and learn from you on kind of what you have found to be useful, because again, with health equity, for sure, it's been about progress, taking steps to advance health equity, not like, oh, we've got here. So it's really important that we all kind of embrace this and support each other on this path. So I am going to share. Can you guys see my screen? Is it sharing my screen?
There we go.
And there we go. And I'm going to move it to presentation mode. There we go. Okay. So it's interesting. I wanted to kind of just introduce this topic and just talk about kind of how we as a community health center in East Tennessee, how we have been working to improve kind of the behavioral health care we're providing and how we can address the equity issues that we've seen as we've gotten into this space. So at first, I thought I would just give an overview. As an organization, Cherokee Health Systems, we are a federally qualified health center and a licensed community mental health center and a licensed alcohol and drug treatment center. We started out in the rural mountains of Tennessee in 1968 as a community mental health center, and then really grew and went into areas where there was need. And what we realized is for many of the people for whom we were providing behavioral health services, they were not getting any medical care or primary care services. And so we, at that point, started partnering with the Bureau of Primary Care. And because we were a safety net, we were in counties where there was nothing. And then our clinical model of integrated primary behavioral care really started in 1984. So we have about 40 years, people talk a lot about, our advancement in this area. And it's because we have a lot of battle scars. We've been doing this for 40 plus years. And so we've done a lot of it, and it has just become the way we provide care. And what we're known for is this model of integrated care. The story I'm going to share with you today is specifically about our journey to improving care, but within the context of cultural humility, and using this really as an example, but a frame for how we continue to advance health equity and behavioral health within our organization. So we're from the mountains in Tennessee. As I mentioned, blending behavioral health and primary care is a key part of our model and our mission. It's not a separate program. Health equity it's almost inculcated into the DNA if you're a safety net health system, right? But it is something that is very intentional in our, for us. Clearly, outreach and engagement. Virtual health for us, we've been doing now 22 years. We've been engaged in telehealth, virtual health, and we got into it again. Everything we've done is just out of desperation. I mean, we just get desperate, and then we say, all right, we have no resources. We're in the mountains of Tennessee. Okay, we didn't expand Medicaid. What can we do? So telehealth was a desperation move by our director of psychiatric services 20 plus years ago. He actually came from the entertainment industry. And we had to get psychiatric services into counties that were so far apart. It was 4 hours of going up and down mountains. And so he went to Lowe's and in the clearance bin found some tools and literally built our very first telemedicine studio. And since that time, of course, we've expanded. So now like 40% of our behavioral health services are via telemedicine. Training and education has been a high priority for us, again, because of desperation. It's very hard to hire staff, providers, clinical pharmacists, you name it, medical, behavioral health. And so we started growing our own. And so we have a robust training program. We are a learning health system, and that has made us so much stronger and has also helped us connect with the community on multiple levels because we're a area health education center. So we'll connect with HOSA programs. We can hire people and connect with people in the community. They can do rotations with us. We can utilize and leverage our partnerships with academic institutions to really help a number of people in our communities get into the healthcare field. So that's been really neat for us. And finally, healthcare analytics has been an area, particularly the past 10 years. It's just so much data that we have to collect. We might as well use it to do some good. So we've really gotten into the space of using the data in a way that's actionable and useful for us. That's a little bit of our overview and our mission. We are a very wide state. Tennessee it's 7 hours from Knoxville, Tennessee to Memphis, which is on our west side of the state. It takes me just as long to drive to Memphis, Tennessee, as it does for me in Knoxville, Tennessee to drive to Detroit, Michigan. That's how far the state is. And people really, in terms of culture, they really say it's 3 different states in one: East Tennessee, Middle Tennessee, West Tennessee. So just in terms of our populations and the communities we serve, we started out in a very rural area, small counties in rural areas in Tennessee, in the mountains. We have patients who live in caves. Certainly we have clinics bordering Kentucky, North Carolina, Georgia, Arkansas, Mississippi, Virginia, and those rural areas in terms of the Appalachian Mountains are incredibly underserved, very impoverished. There's just a long history of marginalization with this community. And then we also are in urban areas, Knoxville, Chattanooga, Memphis. We see, people in our urban areas. And so in terms of racial and ethnic diversity, we have Black, African-American, and African. So I should add that African. We have a growing number of refugees. Now they're new Americans. And in fact, we have a new American clinic. So we are a hotspot for refugee resettlement from these countries: Africa, Middle East, Eastern Europe, Russia, and migrant farm workers, agricultural farm workers, Latinx population, and then we're a homeless health center and a public housing health center. So as you can see, we have such a rich set of communities who we are part of and partner with us. And each of the people in the communities, they've been our teachers. And what we've learned is what seems to fit for one doesn't necessarily fit for another. So very early on, by listening to our patients, watching our patients, and actually hiring from within the community, our organization has been transformed, but we are continuing to change and grow because we are recognizing our job is to meet the needs of the people, to understand and kind of co-create a care model with the communities we serve. So the next step, and I want to give the basics of who we are. So then you can understand the framework and the foundation of how we've approached peripartum postpartum depression. Is we are an integrated healthcare system. We have clinical, behavioral health providers, licensed behavioral health professionals, typically clinical social workers, clinical psychologists as part of the care team. In primary care, they see patients in the exam rooms. We have consulting psychiatrists, community health coordinators, peer navigators, peer wellness coaches, and then we have the continuum of community mental health services with a number of clinical therapists, psych providers, et cetera. For us, we have a shared electronic health record. There's real-time communication. We want our clinical practice to be informed by what our patients need, what's patient-centered, but also informed by data, because it's important for us as much as possible to use every bit of our horsepower to provide high-quality, safe care. And certainly, as you've seen, we see and serve many populations who've experienced trauma, continue to experience trauma, have been marginalized, are under-resourced. So our ongoing journey is to build a place of safety, cultural safety. So that is a little bit of the context. So in this path, I'm kind of giving you the overall foundation, and I'm going a little bit, I want to give you now kind of our philosophy and principle that has been developing over time in terms of our equity considerations. So number one for us is access. If you're a primary care integrated organization, we are about access to care. And we also want to provide the highest quality care. And in addressing those issues, we look at these four main areas. Structural, what are the structural barriers that are present? What are the provider barriers? I mean, we can be all wonderful, great mission-driven people, but we're fooling ourselves if we think that we do not have a bias in how we approach things. The individual cultural issues, and certainly the historical trauma. And I'll just tell you, we're learning every day, but at the beginning of this pandemic, we were going out into our community and working with our community partners to do testing for COVID-19. This is like within the first 3 months of the pandemic in 2020. And we had to work closely with our ambassadors and our community partners, because people were convinced that by testing for COVID, they were actually being given COVID, particularly in the African-American Black communities. They were saying, oh, you're either putting a chip in me or you're giving me COVID. And so everybody remembered the Tuskegee study. And so when we went in to do our first testing event, there was so much pre-work that happened for 2 weeks leading up to it in terms of support and education, recognizing we could have the best testing event in the world, but if nobody came because they thought they were going to be given COVID, then it would have been a fail. But if we had not paid attention to that, then we would not have been able to really provide that service to the community. So I share this with you because we're going to go back to it later when we talk about, and I tell the story of our experience with depression during the perinatal and postpartum period. So the next step in our process that we engage in is to identify, challenge any biases we have these conversations. I have to tell you, they are not easy conversations. So if you're going to go on this journey, and I'm sure you all know this because we are all on this journey, whether we want to or not, or admit it or not, you have to have these conversations, and then you build on it so it then becomes part of a process of quality improvement. And this is the path that we took with depression. So now let's talk about where we were faced with and what we are facing in our community in East Tennessee. I will tell you this, it is very different, I am sure, from your health centers in California. My guess is that a lot of what we have gone through in the last 20 years, you probably experienced a lot earlier, and you have a lot more maturity in this process than we do. So I really am coming from a newbie state that for us, over the past 20 years, we've experienced 200% growth. And I mean like every year, 200% growth in our new communities, and it is diverse. So I have to say, first of all, when I don't like this grouping of Latinx, Hispanic, it's the language or lexicon that is often used, but I'm from India, and I know that there's no such thing as being Indian, that the state I come from and the community I come from in India is very different from every other state. We have a different language, we have a different culture, we have different foods, etc. So I just want to acknowledge that and just say, I wish I had a better way of grouping of people, but it is the term that is being used more often. But I will say that our communities are diverse, and the families we serve who come from Mexico and Guatemala and Honduras are all very different in certain ways. So our goal is to be as sensitive and humble in learning as possible. So I just want to acknowledge that at the get-go. When many of these community people started, when many of our patients started coming, there was nothing in the community. They came originally as migrant farm workers. And so they came, and literally in some of our counties, there would be 1,000% increase. And it was primarily around agricultural work. And that soon, once the families, and we would see families come in, they would come for the season and then go down to Florida, come for the season, then go down to Florida, come back up. What happened is we opened up a pediatric clinic in the middle of all of these farms because people were having babies and they needed care. And then we realized, wow, nobody's getting prenatal care. Nobody's getting prenatal care. So we opened up in the pediatric clinic, in the pediatric clinic, we opened up prenatal care. We recruited, OBGYN nurse practitioner who spoke Spanish. We got trained in the centering pregnancy model. We ran a centering pregnancy program in Talbot, Tennessee, in all Spanish. We had our team of promotores. We had other people who would go to the farms, engage patients, bring them in, and we would have these prenatal centering pregnancy groups. That's how it all started. Some of the key factors to be aware of in terms of what our patients have been facing and faced, certainly poverty. People came with nothing, literacy, education. The immigration trauma was profound and continues to be profound. And I have to tell you, our staff would come, you would listen to stories about the immigration journey And it was so compelling. And we actually still have that issue today, but now we have community infrastructure. We actually was huge for our communities to have Hispanic Chamber of Commerce, start different community centers and churches that actually were made up of community members. But imagine the beginning, it was nothing. And I remember when my family came from India, there were 2 Indian people in Birmingham, Alabama. And then my parents and me came and we doubled it in 1971. So we know what that's like. The access to care was incredibly limited. People were and still are very afraid of deportation. I will tell you what was fascinating is for many people, coming to Tennessee was their first experience with discrimination. So if you come from Mexico, Colombia, Guatemala, you don't experience it. And it was coming to East Tennessee. It's very, very difficult. But even as recently as 2 years ago, in 2019, we had 2 absolutely horrific ICE raids. And we had ICE staff outside our clinic. We had our clinic staff, and we've been hiring from the community. So we actually had family members of our staff who were captured by ICE and then taken to some centers in Arkansas and Alabama. We would go to the churches where patients were hiding. There were churches, there was a network of churches that hid people in our community. We were sending our teams there every night to bring food, medicine, supplies. People needed insulin. So this is a very real issue for us. And what we're seeing now is a transition in the family structure from this migratory pattern and people coming to people really settling, now stronger community supports. Now we have these kids, and what I love is we actually have staff who are adults. They're in our clinic. They are our staff, but they first were seen in our clinic. They were babies in our clinic when their parents came in. So that's always, they're like, oh, they know this organization. So that's been exciting for us. Okay, so now that I've set the stage, I'm going to talk a little bit about this very specific issue. So we have been providing prenatal care, women's health for many, many years. We knew that depression was a significant area of risk and concern when people are pregnant. We knew that. We looked at the data and we said, wow, if you look at meta-analysis, 23 to 51%, almost half of Latinx patients during this period experienced clinical depression. It is a problem. It is an issue. So we did what we did with everybody else. We screened, and the US Preventive Services Task Force says you need to screen. So we got the Spanish version of the PHQ, we got the Spanish version of the Edinburgh for postpartum depression, and we started screening. And guess what? People started, everybody was a 0. We were like, what is going on? Everyone's a 0? Is everyone really that happy? And then we would go into our group. This first started in our prenatal group, in the Centering Pregnancy group. And now it's all morphed into different kinds of interventions and processes. But at that time, we had women talking about withdrawing from things that they enjoyed, the feelings of learned helplessness, the feelings of low self-worth, the self-criticism, feeling judged, difficulty sleeping, not being able to get things done, feeling exhausted all the time in a way that's very different from just pregnancy exhaustion. And we were looking at what we were hearing from people and seeing, and then we would look at the screening scores. Look at what people were saying and look at the screening scores. This was a real test of our system in terms of what is quality improvement and advancing health equity about, because we could have just say, wow, our care is so great, nobody's depressed. And on paper, we look great. It's fine. But it was really our staff who came back and said, something is wrong. something is wrong. And so then we embarked on a process. We stepped back saying, okay, this may be happening, but maybe just following the US Preventive Services Task Force and what has worked with us for the women we, not just women, but patients we serve in Appalachia who are pregnant, maybe it's different because we were seeing, you know, the typical rates of depression. Maybe this is what it is. But here is what we did. We questioned it. And so we said, let us step back. Let's step back. Let's go back to basics. And this is a process. So when we talk about what I hope you can learn from our experience is not the specifics of this population, this problem. It is the process that is important for us to think about in applying it whenever we're faced with a discrepancy like this, where we are watching patients and we're looking at data and there is a disconnect. So number one, we reflected on ourselves. We said, are we sending messages? Are we doing things? Are we perceiving things? Do we have biases in ways, even as something is saying, oh, I'm so excited you're having another baby. I love taking care of your other babies. And this is so great. And your family must be so happy, whatever. Already, are we reinforcing certain expectations and creating that environment? So we had to go through some deep self-reflection, self-awareness. And then we read, I mean, for me and for us, I'm like, what's been published? What do we know about these issues? And then we collaborated with our patients and our community. And it was wonderful because we have a team of outreach workers, community health workers who are from the community, and they really helped guide us in this process to the point where we just, even to this day now, they're the ones who we just have integrated into our prenatal care. So whenever they go to the ultrasound, our community health workers just go with every patient. They just are just integrated in that way. And this is what we learned from knowledge acquisition. It was really enlightening that people were talking about this. Once you go deeper and look at some of these statements, and this statement was very powerful to me this actually just came out, but I mean, this is the kind of stuff we looked at. I don't have time to be sad. You withhold what you are feeling so you can have a family. This was, I mean, it may seem, oh, natural, but for us, it was very new. It was just something, add my name to the chat. Oh, I see. Okay. I'm sorry. I was looking at your chat, Marie. So we did this deeper dive into this. I'm trying to advance. So this was a study that was done where they actually did focus groups and just listened to what these patients were saying. Pregnant patients, the value of the family is a value for me. And depression, if I manifest it, then I lose my family. If I say I feel bad, I will be judged. And that was, I will tell you, when we talked with our patients and community, this came up again and again and again. I will be judged. My mother-in-law, my friends, I will be judged. We heard this so often. They will not understand me and I will lose my family. It is first what the children want. In society, a mother who does not, this was another one, who does not suffer is a bad mother, is selfish for society. This is a good myth, but also bad. Suffering connects you with your children. So this really was eye-opening for us, and some of these stories, and it was these themes again and again. And so we realized that as part of our self-awareness, we had to recognize certainly the cultural mistrust because we were just giving them screening like we would taking labs. We had to acknowledge protective factors that were already there in the community. However, when particularly early on, when people moved to East Tennessee, those protective factors were not there. You didn't have 15 relatives coming and doing everything for you. So you would have 4 or 5, you'd have several kids and you're trying to do everything that the structural characteristics of that care setting, our interpersonal characteristics of our staff, that we would hold showers, baby showers. And we were giving the same for everyone in the group, and we were giving the same message. This is happy, happy, happy. And we were also reinforcing this. And at that point, people were feeling like, I cannot tell Dr. Warden or Julie that I am feeling deeply, deeply sad and I'm suffering. They will feel so bad. They will feel so bad. And so that was really eye-opening and enlightening for us, really. And it was only through this ability to kind of step back. And I love this, image of self-awareness, because it really helps us think through all the components of what goes into culture. So here were some of our critical learnings from this process: the self-awareness, the knowledge acquisition, and really talking to the community. One is the definition and explanation of depression is uniquely shaped by cultural experience. And the ways that people describe depression. So, we have this with several of our refugees, particularly we have refugees from who are Burundi and they speak Kirundi. There's no word for depression. So people didn't even know, like, how can I say, oh, I'm experiencing prenatal depression or postnatal depression. It's in our language vernacular now, but it wasn't. And what it really meant, and much of it was the physical symptoms of depression. So that was one thing, is people weren't talking as much about being sad as really talking about withdrawal and this, like, just not being able to do things. The stigma, very real stigma in the community, the fear of judgment. I told you, people were judging themselves, but they also, like, really were being judged by others. And it's a collectivistic culture, but the people were really judging each, if they felt like you were not doing a good job, or you were not perfectly happy, that judgment was there. And here's the other thing that is actually growing now, and that is, after having maybe 1 baby, 2 babies, women our patients now want to look at their careers and they want to go to college, particularly our patients who've kind of grown up in the United States, mostly children of the migrant agricultural workers. And they're still expected to be the mother, and that should come as the very number one. And so I talk about this, the expectation of self and others. And in fact, I have a patient right now, and she has 3 children, and she was pregnant, and she just said, I want to go to college. And she's taking 1 class at a time. And she said, I will graduate with my associate's degree when my oldest graduates high school. And it's this tension that is really hard and very difficult for people to talk about. So people thought, okay, suffering and sacrifice, that's what I should do to be a good mother. How do I even talk or process these emotions? And so these were our critical learnings. It did not happen in 1 week or 2 weeks. I'm talking about a 6 to 8 month process. It was, and we're continuing to learn. Like I said, some of these issues are now newer for us, particularly now where we have our younger pregnant patients who want a career, and they're looking at the archetype or prototype of more American motherhood, or the American individual, and they're like, hey, I don't need this. I could be doing this, this, and this. And how do you reconcile it? My patient who is taking a class one at a time. She still lives with her parents, she and her husband and her kids. Her grandmother also there lives. I mean, she's not completely separate from that. So here's what we did in terms of adaptive clinical practice when we talked about at every point on changing our perception. Number one, we recognized we had to not just do screening. You couldn't just give the screen, which is what we were doing. It's just, here's a screen, just like, pee in a cup, do this, here's your screen. We had to train our staff in supportive talk. And it was not talking about depression, but it was supportive talk is taking the time and talking about what kinds of things are typical to experience during pregnancy. Thoughts and feelings, labeling emotions, understanding what is this like for you. And that supportive talk piece has been a game changer, absolute game changer. It doesn't have to be 45 minutes, but it's 5 minutes every single time. 5 to 7. The supportive talk is something that we are finding, particularly with cultures where there isn't that natural inclination to share, and we don't have that language. We are seeing that as being absolutely critical. The other 2 steps that were pointed in the literature is one, it's self-directed care. And this drove and I'm a licensed behavioral health provider, this drove us crazy because we just wanted everyone to engage in, we were like, I know what works, individual psychotherapy, behavioral activation, then you do cognitive restructuring, let's do problem solving. We had to respect that there were people who said, I don't want to do that. And we just had to say, okay, let's just continue to monitor it. But that's hard for us because we are action-minded. But we had to be very clear, and this is something the literature is also clear about, is self-directed care. The third piece that came from the literature is a stepped pathway. So a stepped pathway is, number one, with our patients, always use one's own resources. What is already there? So particularly with our Latinx, Peri, Hispanic patients, what's already there? And it's much better now that we have existing systems. Then secondly, look at a formal support system. And only then do we go to a behavioral intervention. So with the use of one support system, it's like, what are the things that, it's almost like a behavioral activation, but what are the things that you stop doing, or what are the resources, is there a friend you can walk with, etc. Things that you have done. Do we link you with one of our promotores as like a mentorship model, etc. So those 2 things really were very powerful. We used to go directly to behavioral intervention, and we just don't anymore. We just don't. And just in going through the process, we realized that we had to really transform and change the way we scheduled and the supports that we built in. And really, and this could be different in different places, but for us, antidepressant use, which among our Appalachian population was the first go-to, because for them, treatment is medicine. So for our patients in our Appalachian mountain communities would say, just give me a medicine, doc. I get it, I'm yelling at my kids, I can't do this, give me a medicine. For our Latinx Hispanic populations, it was no medicine, I don't want to put anything in my body, and then that only after delivery. So we may talk about it, but it's your choice, but it's just been our experience. So as you can see, what we have done is adapted clinical practice based on our learnings in this process. So I want to just take you back to, let's see, this. Look at the structure. We looked at our biases, we had the conversations, observe, listen, learn. We had to teach ourselves new skills. We had to revise our policies and our practices. A PHQ of 0 or Edinburgh of 0 means nothing to us with a patient who is in this community. So, and then We continue to provide training. So whenever we have a new nurse, particularly in women's health, we're like, okay, this, just so you know, the way we have to adapt this for certain patients, this is what we do. And then this then becomes part of an ongoing quality improvement process where we're always doing it. So I want to link this with you because I don't know what challenges we'll face. I don't know what you have. It's the process that has been very important to us. So I'm just going to wrap up with our next challenge. I thought I would share with you, and I don't want to say challenge, really, it's our journey. This is a picture drawn by a 5-year-old Afghani boy. We have started to see, we've got now our Afghani refugees. We are a resettlement site for a number of the Afghani communities, and they're incredibly diverse. So, we've got Turkmen, we have Dari, we have so many different languages and communities. But in the waiting room, this little boy, right before Christmas, look at this, it says, "Merry Christmas," and he drew a flag, Afghanistan flag and US flag. And I was thinking, they're gonna teach us, and I don't know what is gonna come. I don't know what are gonna be the things that are different that we have to adapt and be responsive to. But what I do know is we are gonna go back to that process, give ourselves the space to develop that. And we are going to look at this as an experience of cultural humility, where we're going to learn, and not necessarily in the easiest or most direct way. It's going to be this co-created process. So that's a little bit about our journey. I will tell you I cannot say this is causation, but I will tell you that you look at our UDS numbers for low birth weight, access to prenatal care, they improved dramatically. We met all our targets within 3 years when we had just been stagnating, and low birth weight was killing us, and not getting people in prenatal care was killing us as a UDS metric for all the FQHCs there. But we are now meeting or exceeding them. And you can't help but wonder, is it because we created this space that was safe for people to come and get good prenatal care? And they were able then to integrate other components of good self-care for prenatal health, so their babies could be healthier. It's probably a lot of things, but I just did want to share that. So with that, Marie, let's open it up for questions, comments, feedback. I'd love to hear from all of you in terms of your experiences in this area, if there was something that resonated with you in particular. Thank you.
Wonderful. Thank you so much, Dr. Khatri. It was great to hear about the impressive work that you're doing at Cherokee Health Systems. I'll remind everyone on the call, if you have a question, if you have a comment, please put your name in the chat. I'll call on you and you'll have an opportunity to open your line and have more of a discussion. I will start with a question, which is, just thinking about that process map you just walked us through, the equity considerations, as we all know, this requires a lot of leadership and championship at organizations. And so wondering if you can talk a little bit about how did those conversations start at Cherokee Health Systems, and what kind of recommendations do you have for others on the call who are just kind of starting these conversations or at the beginning of this work to really drive health equity in their organizations?
So I think, it has to come bottom up and top down. I really have, we try not to be a hierarchical organization, but in the health equity space, I have found that it's incredibly powerful to have leadership that says and sends the message and prioritizes this is important. And if we have to make this 15-minute prenatal visit 30 minutes, so you can really provide equitable care for a population, then we'll do it. And that is absolutely critical. It is sending this message because, we are in a, it's a hard space to be in, but, people have very different perspectives about equity and how much emphasis to put on it. I think there's just been a lot of tension around it. So you kind of have to just step up and say, okay, this is important. And then linking it to mission and also linking it to what we're doing. So from the most selfish perspective, you know, if we want to provide good care, we have to do this. If we have to, I mean, that's what we have to do. So I think the leadership, and it's not just the statement. And so this is my soapbox. It can't just be performative. It can't just be writing, you know, a really pretty statement or whatever. It has to be practice. And so the practice of this is in all the decisions you make day to day. And I make so many mistakes, and we all do. I mean, we just do. And we make the wrong call, and we just, you know, we stumble, and then you come back and you say, you know, I shouldn't have done that, or, oh, you know, but you accept that in this space, there is no perfection. You have to stand in this place where you just embrace it's scratchy. It can be messy, but I do think it's important in the actions. And that is when people ask you questions, how you respond. When you make decisions about every practice point, how you respond, people are paying attention. And it is hard. It's not easy at all. But I do think that the leadership, I got to tell you, I think, and I will tell you, people on our frontline staff have schooled me. And so even if we have that culture, I look at Dr. Khatri, you did not get that right. You did it, which is good. And I'm like, oh my gosh, no, I'm so sorry. But you have to have that and just have that mindset. But I think this is one area where it's absolutely important for leadership. Again, you can't just, you know, be performative in it. It is really about practice at the most granular level.
Thank you. Any questions, comments from the group? This is really your time to get what you want from Dr. Khatri and from each other, really.
And I would love to hear, you know, in the Southeast, we look to California as, oh, everyone's really progressive and, you know, people talk about things. Is that the case? Do you feel like you've really progressed and are at a good place in terms of advancing health equity? Or do you feel like there's still some real challenges even at the basic level? I can tell you, I mean, you don't even need to know in the Southeast, it really is like a major uphill climb. But I would love to hear from you all.
I will just share, and then of course, if there's no comments and questions, I don't need to keep us all here, but would love to hear from anyone if there are. I know California is progressive, as I guess you could say, but I think we're also on our own journey that looks different, but it still exists. Yeah, it's different.
And that's why I think it's good we have these conversations, because the content may be different, but what we have so much to learn from each other is the process, right? And to kind of walk with each other in this process,
right?
And realize everybody's path is different. But, you know, what are the things that we know help? Self-reflection, reading, learning, dialogue.
Yeah. Yep.
Everybody's maybe eating lunch.
Yeah, which is good. Eat away. Well, my colleague Christina just launched a poll. This just helps us better understand, you know, how this content is helping all of you and areas we might want to improve. If you have additional questions, feel free to contact Christina or I. We're happy to follow up with Dr. Khatri. And thank you so much, Dr. Khatri, for this presentation and sharing your work. We really appreciate it and appreciate you taking the time to share with our network.
Thank you. Everyone have a good day. Take care. Thank you.
Thank you. Thanks, everyone.
Bye.